Hello, everyone. Thank you for being here. My name is Amaya Chinawolker. I am a second-year internal medicine resident, and today we'll be talking about a case of atrial fibrillation with rapid ventricular response secondary to massive uterine chondrosarcoma. So the first thing we'll do is kind of go over this particular tumor. Uterine chondrosarcomas are exceptionally rare and a malignant form of uterine sarcomas. Uterine sarcomas themselves account for about 2 to 5% of all uterine malignancies, but uterine chondrosarcomas are exceptionally rare, and there's maybe about a couple isolated case reports in the literature. These tumors are aggressive. They have a high risk of metastasis, associated poor prognosis. Typically, they're diagnosed with histological evaluation after they're surgically removed, but time to time they can be very difficult to separate from other types of uterine sarcoma or even benign fibroids. But failure of timely management can lead to increasingly poor prognosis from either mass effect and rapid growth or potential hematogenous spread. So our case today involves a 59-year-old female who had a medical history of heart failure with a preserved ejection fraction, non-ischemic cardiomyopathy, atrial fibrillation, pulmonary hypertension, and presumed uterine leiomyoma. She showed up with 1 week of dizziness, fatigue, orthopnea, and dysuria. She had a history of being severely non-adherent to medication. Her insurance plan was not the best, and she would manage this by spacing out when she'd take her medication. So instead of taking it daily, she'd take it every couple of days. She was typically lost to follow-up. She actually had this uterine mass diagnosed in 2022, but she was told at the time that it was benign, but also missed multiple follow-up visits. She was previously offered surgery, but she refused as she was concerned about poor outcomes. On exam, the pertinent findings include scleral icterus, tachycardia with an irregular rate, no gallops, rubs, or murmurs. Her abdomen was rigid, distended, and non-tender with no rebound or guarding, and she had 3+ pitting bilateral lower extremity edema. Vitals showed that she was afebrile, mildly hypotensive, tachycardic, and she was on room air. She had an elevated white count, as well as an elevated BUN and creatinine, and low sodium. Her bilirubin, both total and direct bilirubin, were both elevated. An EKG confirmed AFib with RVR, and an echo, the results of which were obtained after her transfer, showed an ejection fraction of 40 to 45% with moderate tricuspid regurgitation, a right ventricular systolic pressure of 47, and global left ventricular hypokinesis. Here we show the abdominal CT with contrast, which shows the large uterine mass with sagittal, coronal, and transverse cuts. This mass was about 24.5 by 26.2 by 26.3 centimeters with an estimated volume of 8.8 liters. The last time she had imaging around the time of her diagnosis, the estimated volume was 3.1 liters. So this was pretty aggressive growth in 3 years. The arrows point to areas of severe compression near the aortic bifurcation, lower IVC, and common iliac vessels near the L3 and L4 vertebrae. For management, she was started on IV fluids, antibiotics, and a diltiazem infusion. We consulted gynecology, who recommended that she be transferred to a facility with gynecology-oncology capabilities for surgery. During this period, she was stable. Her rates were well controlled in max 130 beats per minute, and she initially was not wanting to do surgery, but after discussing her case with her and the complications, she did eventually agree to have surgery done, after which she was transferred to a capable facility where she received a total abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and bilateral ureteral stent placement. Pathology confirmed a malignant, poorly differentiated neoplasm of the uterus with extensive necrosis and focal cartilaginous differentiation with heterologous elements, all consistent with the finding of uterine chondrosarcoma. The tumor measured 32.5 centimeters in the greatest dimension. So we were able to have her transferred to a capable facility, and she was able to have the tumor out with negative surgical margins, and that was it. Except it wasn't. Unfortunately, post-op, she developed a pelvic hematoma, leading to hemorrhagic shock and another episode of AFib-RVR, which required ICU care and vasopressor support. She did require a massive transfusion protocol with 11 units of packed red blood cells. She required continuous renal replacement therapy. She was intubated to protect her airway, and eventually her left ovarian artery and bilateral internal iliac arteries were embolized. Her AFib was then managed with metoprolol, digoxin, and she was slowly weaned off vasopressors and extubated. She was then able to be discharged with a much more manageable regimen, including metoprolol, succinate, and amiodarone to control her atrial fibrillation. To kind of wrap up this case, uterine sarcomas are highly aggressive, and without treatment, as you saw from imaging, they can grow rapidly and lead to complications from either mass effect or even tumor metastasis. Delays in diagnosis and care can increase this risk, both of mortality and of postoperative complications. And given the rarity and poor prognosis associated with primary uterine chondrosarcomas, it is vital that once they are recognized, they're evaluated and close follow-up is encouraged. And these are my references. Thank you so much for listening.